Hi, this is Dr. Chestnut, and I'd like to thank you for joining me as we discuss imaging of the normal and diseased esophagus. Not like you have a lot of choice in joining me because this is, remember, testable material. But this is my first time in doing one of these recorded audio, video type presentations. So if you have any suggestions on how I can improve this, I'd like to hear them. Also, if you have any questions on the material presented in this presentation, please, you can email me at, my email address is jeffreychestnut@rossu.edu. It's right there on the page. Or please make an appointment to come see me in my office in classroom, or it's right above classroom 6 in the Pathology, Physiology, DCM building. But for now, let's go ahead and get started with imaging of the normal and diseased esophagus. As always, here are some objectives for you, and as always, I strongly recommend that you use these objectives to help guide your study. Now, you've already had several lectures on the esophagus. Way back in first semester, you had a lecture on the superior and posterior mediastinum, which was given in week 6. By Dr. Sheila Nunn. Specifically, the esophagus is spoken of in slides 22, 31 through 32, and 42. 2 weeks later, back in this first semester, Dr. Nunn also gave you a lecture on GI system embryology, and the esophagus is mentioned in slides 11 through 13. For imaging anatomy, I gave a lecture in first semester that you can look up in your eCollege folder. And Dr. Naj included the esophagus in some of his slides when he talked about the root of the neck and prevertebral region. Now in week 13 of Fundamentals 1, semester 1, the pharynx and larynx lecture is given. You might want to take a look at that for the pharyngeal type stuff. This is a slide on here that was reproduced from Dr. Cotofana's lecture. Dr. Cotofana is no longer here, and therefore I can't give you particular slides because someone else will be lecturing and they'll publish their own material. A lecture I really do want to call your attention to, and I would strongly advise you to go back and review this, was given last semester to you, week 4, and that's Dr. Wright's lecture on oral and esophageal physiology. Physiology and pathology are very tightly intertwined, and I think it would help you understand a little more about the pathology if you really take a look at that physiology review. So I'd urge you to do that. And then, of course, this lecture is strongly associated with the lectures by Dr. Loy on the pathology of the esophagus, and Dr. Dyer on some of the clinical conditions of the esophagus. Those will be in the same eCollege folder as this lecture. The first study I'd like to cover is something called the barium deglutition study. You may also see this on your hospital ordering system as a speech pathology barium swallow. The impetus that propels a bolus of food down the esophagus into the stomach begins in the mouth. The act of swallowing is very complex, involving the tongue, the soft palate, propulsive muscles within the posterior oropharynx, and the epiglottis, and all of these have to work in concert. So any impairment in this process may result in serious consequences, such as aspiration and possibly choking. Now, it's really beyond the scope of this presentation to go into the details of the act of swallowing. There are entire books written on this subject. But enough to say that the act of deglutition can be evaluated using fluoroscopy, or in other words, real-time radiology or real-time radiography. Now, typically this is done in the Department of Radiology, but it's not usually performed by radiologists. This is normally performed by speech pathologists who are specially trained in this type of study. Radiologists, in fact, tend to try to avoid this type of study. Not only is it complex and time-consuming, but there's a very good chance that you might get barium spit on your shoes or your trousers, and we kind of like to avoid that whenever we can. So We leave this to the speech pathologists. But normally what will happen in this is the patient will be given barium or have barium added to different food products of different consistencies. So they may be given thin watery barium and thick viscous barium. Sometimes we'll mix barium with applesauce or pudding. Sometimes they'll mix barium with ice cream, which the patients tend to like. They'll even put this kind of thick barium paste on graham crackers. Now, this is a point where I need to warn you that barium paste on graham crackers looks delicious. It looks like that marshmallow fluff stuff. It does not taste like marshmallow fluff. So if you're wandering through the Department of Radiology at some time and you see a graham cracker with some marshmallow fluff looking stuff on it and you sneak it away and pop it in your mouth, you're likely going to be in for a surprise. But anyway, by evaluating the swallowing mechanism with each of these consistencies, the speech pathologist can make recommendations on how or even if the patient should be fed by mouth. Sometimes the speech pathologist will say, no, it's too dangerous, he's going to aspirate, and he needs a gastric tube. They can also prescribe different alterations in the diet. For instance, if the patient tends to aspirate thin liquids, they may say, okay, he can only have thick liquids or he can only have kind of semi-solid things like applesauce or ice cream, things like that. They may also sometimes recommend various maneuvers, such as bending the head forward, flexing the head, or flexing the neck while the patient swallows, or putting pressure on one side of the throat, for instance, while the patient swallows, or even putting pressure on the larynx. Now, over on the right side of the screen, you'll see a image, and this isn't really to anything that you have to know, but it's just to illustrate some of the types of things we do this for. Often we do this in patients who have had strokes, or sometimes patients who are mentally disabled and they have a hard time swallowing, patients maybe with muscular dystrophy or ALS. In this case, this fella has had a laryngectomy. He'd had laryngeal carcinoma and has had a laryngectomy. And what this is showing, the asterisks, is just showing that he has premature leakage of barium before he even starts the swallowing process. And if this happens, then you're not getting all that swallowing in coordination, and the patient can aspirate. I'll put a barium deglutition study YouTube in your eCollege folder. Again, there's no real reason to memorize it, or there's no real big teaching point that you need to get from it that I'll put on my test, except just to see kind of what happens, what the swallowing mechanism looks like, and that we can do this down in the Department of Radiology. Okay. The barium esophagram is the study that we radiologists use to evaluate the anatomy and the function of the esophagus. Usually what we do is we have the patient ingest effervescent crystals, kind of like Alka-Seltzer. We'll either pour them in a small cup of water and have the patient drink them, or we'll have them swallow them dry and wash them down with water. But these crystals create carbon dioxide gas within the stomach, and they inflate the stomach. It also, when the patient belches, allows for inflation of the esophagus. It also inflates any portion of the stomach that lies above the diaphragm, and so we can see what's called a hiatal hernia, and we'll talk in a future lecture a little bit about hiatal hernias, but we can see those because of the inflation. We then have the patient swallow a thick formulation of barium. It's actually barium sulfate, BaSO4, but we'll just use the name barium from now on. We observe the swallowing mechanism, and with nothing like the detail of the speech pathology barium deglutition study. We can see, in this case, the vallecula is noted here, and the piriform sinuses. We'll usually have patients do various maneuvers by which we can see the barium-coated valleculae and piriform sinuses. We'll have them hold out the sound E, or we'll have them close their lips and blow out their cheeks like Dizzy Gillespie blowing a trumpet, which I realize is a totally senseless pop culture reference to most of you, but if you Google Dizzy Gillespie, you'll see what I mean. Great trumpeter. But we can see then if there's any irregularity or mass within the valleculator piriform sinuses that we may then, or we will need then, to have someone take a look at it with endoscopy. Our primary evaluation is of the esophagus itself, and the radiologist can observe in real time the peristalsis of a bolus of contrast as it's propelled down the esophagus into the stomach. And by using both dynamic and static images, the radiologist can observe and evaluate diverticula, areas of stricture, masses or mass effect, or motility disorders. Before I get into pathology of the esophagus, I'd like to touch briefly on esophageal peristalsis. Normally, the esophagus acts in a coordinated fashion in order to propel a food bolus from proximal to distal and into the stomach. Okay, this requires coordination of multiple constrictor muscles within the esophagus, as well as coordination with the lower esophageal sphincter so that the lower esophageal sphincter is open by the time that food bolus hits it. Any discoordination between the peristalsis or the lower esophageal sphincter, or any abnormality within the motility within the esophagus, can result in dysphagia and other symptoms. So there are three types of peristaltic contractions within the esophagus. The first of these are called primary peristaltic contractions, and these have their origination in the proximal most portion of the esophagus. So when the food bolus passes through the pharynx and hits that esophagus, then the primary peristaltic contractions kick in and serve to propel that food bolus from proximal to distal. Okay, secondary peristaltic contractions are exactly the same as primary peristaltic contractions, except for their point of origin. These don't originate within the proximal esophagus. These originate usually in the mid to distal esophagus. And otherwise, they have exactly the same action and pretty much the same function. They are coordinated contractions that serve to propel a food bolus from proximal to distal. The purpose of secondary peristaltic contractions appear to be to deal with gastroesophageal regurgitation or reflux, and also to help to propel a stuck food bolus into the stomach. Now there's a third type of peristaltic contraction which is abnormal. This is tertiary peristaltic contractions. These are pathologic, but we see these very frequently, especially in our elderly population. Tertiary peristaltic contractions are disordered random contractions that serve no discernible purpose whatsoever. They don't move the food bolus down, they don't move the food bolus up, they're just too random for that. Now if you look on the right hand side of the screen, these are static views, and by static we mean that they're still images, they're not moving, but these are static views from a barium esophagram. And what we see is very typical for a normal barium esophagram. You have a very smooth esophagus, and there is a smooth area of narrowing within the upper portion of the films. But you notice this narrowing isn't the same on each image, and that's because what we're doing is we're catching peristaltic waves in the act, basically. Now, if we were to look at this on a real-time image and under fluoroscopy, we could actually see this peristaltic wave moving from proximal to distal. And the word wave is used very advisedly because it's almost like a wave in the way that it travels. I'll put a YouTube video in your eCollege folder so that you can kind of get an idea of what a normal barium esophagram with these peristaltic contractions look like. Okay, let's start into the pathology. We're going to start in esophageal motility disorders. I hope your esophagus doesn't look like the person's esophagus on this page. This is just merely horrible presbyesophagus, and we'll talk about presbyesophagus on the next slide. The first of the esophageal motility disorders that I'd like to discuss is also by far the most common of the esophageal motility disorders, and that's presbyesophagus. Now, presbyesophagus is a disease of aging where there is decreased coordinated esophageal motility. So there are diminished primary and secondary esophageal contractions with increased tertiary contractions. And remember, the tertiary contractions are those contractions that don't do us any good whatsoever. They don't move the bolus of food up or down within the esophagus. It's almost as if the esophagus is fibrillating. There's just motion with no real effect. Because of this, the propulsion of the food bolus isn't as efficient as usual. Now, I would say that most patients over the age of 70 have some degree of presbyesophagus, and most of them do just fine with it. Part of this is because we tend to eat upright, and so gravity helps assist in the propulsion of the food bolus downward. But if the presbyesophagus becomes a little more severe because of that inefficiency of propulsion of the food bolus, patients may become symptomatic, and they may develop dysphagia or chest pain. Some of these may even have some aspiration. Now, if you look at the radiograph on the right side of the screen, this is a very characteristic appearance of presbyesophagus. Normally, the esophagus should look smooth with one, maybe two areas of smooth narrowing due to the normal peristaltic contractions. In this case, we see a bunch of hills and troughs, a bunch of moguls here that are part of this disordered random contraction. And this is, again, very characteristic of presbyesophagus. The next of the esophageal motility disorders that I would like to discuss is esophageal achalasia. This is something that appears with some frequency on USMLE type examinations, so it's something that I would try to put in my memory banks. Dr. Loy talks about this in slide 4 of his lecture, and then Dr. Dyer talks about it in her lecture as well. And again, I would go back and review the physiology of this with Dr. Wright's lecture. But achalasia is a condition in which the lower esophageal sphincter fails to relax and normal peristalsis of the esophagus is diminished. Okay, this is due to degeneration of the nerves and then subsequently degeneration of the esophageal musculature. On barium swallow, what we see is a dilated proximal and mid-esophagus with narrowing at the lower esophageal sphincter, or the gastroesophageal sphincter, and this gives us what we call a bird's beak sign of the lower esophagus. And we'll see that on the next image. But basically, barium or any food is very slow to enter the stomach. It just sits in that esophagus for a long time because the lower esophageal sphincter is tight. It's not allowing things to get through. Significantly, if we stand the patient upright, we still can't get barium through the lower esophageal sphincter. Normally, with a fluid, as barium is, it's a liquid, the barium sulfate. If we stand the patient up, gravity, even if there's no peristaltic contractions at all, gravity should take the barium through the esophagus into the stomach. But in this case, that lower esophageal sphincter is so tight that even when we stand the patient up, the barium will sit in the esophagus. Peristaltic waves are primarily tertiary in this case. And that's because of the nerve damage that's been performed. But there are few, especially in advanced cases, few primary and secondary peristaltic contractions. So some of the symptoms of achalasia include progressive dysphagia. The patients may have substernal chest pain. Because this food sits in the esophagus and doesn't go into the stomach, they may have regurgitation of undigested food hours later, and significantly, they can have aspiration. Now, when we look at the YouTube video on this is a patient in probably fairly early achalasia, but what you can see is that when the patient drinks the barium sits down in the distal esophagus at this very tight lower esophageal sphincter. Initially, no barium gets through at all. Finally, we'll see a little bit of barium getting through, but that lower esophageal sphincter is very tight, very small, and the barium will sit in the esophagus. And in fact, patients who have had this for a long time, their upper esophagus just gets stretched out and it can become massively dilated. This, of course, is a real aspiration risk, and in fact, it's very common when we do a barium swallow on a patient with achalasia, we will have to put down a nasogastric tube and suck the residual barium out. I mean, we might have that patient sitting around the department for an hour and bring them back, and there's still a ton of barium in the esophagus, and so we'll put down an NG tube and suck it out just so the patient won't aspirate. This can lead to some interesting x-rays, and you can see this is a massively dilated esophagus. Now in a little bit, I'll show you an x-ray of what we call a gastric pull-through following an esophagectomy. And this looks not terribly unlike a gastric pull-through, but this is just a massively dilated esophagus due to achalasia. And you can see the borders annotated by the arrows. And again, because of the narrowing of the lower esophageal sphincter, you get this, what we call a bird's beak appearance. So if this is the head of the bird, you can kind of see how that looks like a bird's beak. This happens to be a little bit of an angry bird because this guy has achalasia and he's not getting enough to eat and having chest pain when he does. Okay, another disease that can cause esophageal motility disorders is scleroderma. Scleroderma is a systemic disease, but it can affect the esophagus, and it generally causes smooth muscle atrophy and fibrosis of the distal 2/3 of the esophagus. Okay, this causes markedly decreased peristaltic contractions, and at first glance could represent achalasia or could resemble achalasia. The difference between scleroderma and achalasia, one of the big differences is in scleroderma, the lower esophageal sphincter is kept open, what we call a patulous, P-A-T-U-L-O-U-S, lower esophageal sphincter. And because of that, if we have the patient who is not getting barium through the esophagus well, if we put them upright, then it readily drains. It goes right through that patulous sphincter. Now what can happen, because the sphincter remains open, is you can get a lot of gastroesophageal reflux, which causes scarring of this distal esophagus and can cause what we call stenosis, or narrowing of the distal esophagus due to scarring. And in those cases, it can look a lot like achalasia. On barium swallow, the esophagus may be mildly dilated, but it's usually not so severe as in achalasia. But again, the main difference is the opening is widely patent. When we put the patient up, barium will just flow right through there, whereas on achalasia it does not. Okay, we'll talk briefly about esophageal diverticula and esophageal varices. Okay, there are several kinds of esophageal diverticula. Dr. Loy discusses these on his slide number 6 on his lecture. But diverticula are outpouchings through the wall of a hollow viscus. So we see these in any hollow viscus. We can see them in the duodenum, we can see them in the colon, and we can see them in the esophagus. And there are multiple types of esophageal diverticula, or several types of esophageal diverticula. The only one that I'm concerned that you know at this point is something called a Zenker's diverticulum. Zenker's diverticulum is fairly common. We see this every now and then. And it's located within the cervical esophagus, just below the hypopharynx, and extends posteriorly and to one side or the other. It's located right below the cricopharyngeus muscle. These are almost always unilateral. They can range from very small to quite large. They're commonly asymptomatic, and we just discover them when we're evaluating for something else, but large Zenker's diverticula can entrap food and create a sensation of fullness of the neck, and you can see you've got this diverticulum here. It can cause narrowing of the esophagus, so it can cause some swallowing difficulties if it's large. But food can come in here and just kind of stay here, and so one of the characteristics of Zenker's diverticulum is regurgitation of undigested food, maybe hours after a meal, because it's just been sitting in this Zenker's diverticulum. This can create a sensation of fullness in the neck, and also just because food have been sitting in there, just getting more and more ripe, can create halitosis. Okay, rarely these can lead to aspiration, but generally not. But this is something, like I said, we see fairly frequently. They're probably best imaged on barium esophagram simply because they really require on endoscopy for the esophagus to be distended by air, and the endoscopist doesn't always get the esophagus as distended by air as you would like up in this upper esophagus, in the hypopharyngeal portion of the esophagus. So usually barium esophagram is the best thing to see this Zenker's diverticulum. Esophageal varices are just varicose veins of the esophagus, and they're caused by usually hepatic cirrhosis and portal hypertension. The blood, because it has a hard time going through the portovenous system in order to drain back into the heart, has to find an alternate pathway. So one of the alternate pathways that it can use is these veins, the periesophageal plexus. So these veins become very large, and what you get on barium swallow is the serpiginous filling defects due to this these enlarged veins, pushing against the area where the barium should be coating. On CT scan, you see all these serpiginous, again, dilated, contrast-filled veins surrounding the esophagus, and this is very characteristic for esophageal varices. This is usually not a subtle diagnosis. These are usually fairly severe. The significance of esophageal varices, of course, is that these things can bleed, and the bleeding can be nasty, and it can be fatal. And so they can go in surgically and clip these, put clips on them. The best thing is if they can reduce the portal hypertension, which is a problem in itself. But if that can happen, then the deoxygenated blood can flow back into the portal venous system. Okay, let's talk briefly about gastroesophageal reflux disease and its sequelae. Okay, so the esophagus should be a one-way street. Food should go down into the esophagus, or through the esophagus into the stomach, but except in rare cases, it really shouldn't pass retrograde from the stomach back into the esophagus. The esophageal mucosa is just not made to handle the acidity of gastric secretions. So reflux from the stomach into the esophagus can be physiologic, such as in the case of vomiting, when the stomach tries to rid itself of, bad food or an infection. But when there's gastroesophageal reflux, or when there's reflux through the gastroesophageal junction, without a useful reason for that, we call that gastroesophageal reflux disease. This is often abbreviated as GERD, which some people say GERD. I don't know, I never liked the term. It just sounds bad to me, so I just say GERD. But in short, gastroesophageal reflux disease is due to a failure of the lower esophageal sphincter, which permits reflux of gastric contents. Now, this can occur due to several conditions, and Dr. Loy mentions these and mentions all of gastroesophageal reflux disease in slides 10 through 18 in his lecture. But some of these conditions may just be a decreased muscle tone at the lower esophageal sphincter with aging. We've discussed fibrosis within scleroderma, and even increased intra-abdominal pressure, possibly due to obesity or a mass, can cause gastroesophageal reflux. In addition, the diaphragmatic hiatus, that hole in the diaphragm that the esophagus goes through, serves to reinforce the lower esophageal sphincter, so that in the case of a hiatal hernia, where a portion of the stomach slides up through the diaphragmatic hiatus, that reinforcement can't occur. And so patients with hiatal hernias frequently, and I would say most often or often, have gastroesophageal reflux disease. So the patient with gastroesophageal reflux disease can present, classically with heartburn, but they can also present with chest pain, the sensation of food getting stuck in their chest, which is usually due to strictures caused by scarring from the acid within the esophagus. And they may wake up with a bitter taste in their mouth because of reflux. In more severe cases, the patient may even aspirate. So they may lie down at night and reflux and breathe that in and aspirate. And in fact, for our patients with chronic coughs, especially if it's more common at nighttime or wakes the patient from their sleep, but even with just chronic coughs that last for long periods of time that we can't find a pulmonary reason for, we need to consider gastroesophageal reflux disease. Now, gastroesophageal reflux disease can lead to ulcers, such as seen right here, where you get penetration through the mucosa into the serosa due to the erosion by the acid. It can lead to strictures, and it can lead to Barrett's esophagitis, which is a precursor to esophageal carcinoma. Now, barium swallow is pretty good for visualizing ulcers and strictures. It is not very good for visualizing Barrett's. Well, in fact, it's not possible really to visualize the changes of Barrett's esophagitis on barium swallow. And therefore, to evaluate the sequelae of gastroesophageal reflux disease, endoscopy is a better tool. One of the things endoscopy can, we can biopsy when we do an endoscope, and the diagnosis of Barrett's esophagitis requires biopsy confirmation. Now, it's also true that we can see active reflux on our barium swallows, where we watch barium go back from the stomach into the esophagus, and we report those on our reports, but I'm not really certain how valuable that observation is, just because barium, again, is kind of a noxious substance. Patients don't like barium. They tend to gag and kind of spit it up. And, this may present a, gastroesophageal reflux that they wouldn't otherwise have, in their day-to-day life. So I'm just not sure how useful this is. Now, we talked about the endoscopy is the best way to evaluate the sequelae of gastroesophageal reflux disease. The best study for to see if there is gastroesophageal reflux is a nasoesophageal pH probe. And this is a 24-hour ambulatory pH probe. You can see this kind of coming around this woman's ear, into the nose, down her throat. She appears fairly happy to have this in. I don't think most of our patients are quite that crazy about them, but I guess to each their own. But anyway, they put this esophageal probe into the mid to distal esophagus and just for 24 hours measure the acidity of the esophagus and see how many times that acidity lowers when the gastric juices reflux back into the esophagus. So I think for the detection of gastroesophageal reflux, the pH probe is the best way to go. For evaluation of the sequelae of gastroesophageal reflux disease, endoscopy is the best way to go. And if for some reason the patient can't have endoscopy, then I think it's perfectly reasonable to do a barium swallow. Of course, the most dreaded and most severe sequelum of gastroesophageal reflux disease is esophageal carcinoma. And esophageal carcinoma has a high association with gastroesophageal reflux disease and with Barrett's esophagitis. Smoking is also a risk factor in esophageal carcinoma, and in fact, as we go through this digestive module, we'll see that anything that causes chronic inflammation of the mucosal linings of the gastrointestinal system has an increased risk of carcinoma associated with that. So on barium swallows, esophageal carcinoma is often seen as an irregular, asymmetric stricture, often with ulcerations into that stricture. Now it can be smoothly marginated and circumferential, but that's more likely to be a stricture due to scarring from chronic reflux, etc. When it's irregular like this one is, and when has a ragged appearance, that's almost always going to represent esophageal carcinoma. On CT scan, when we do transverse images, we may just see thickening of the esophageal walls, and sometimes it can be very difficult to evaluate on CT scan because it can be difficult to tell whether this thickening is just because the esophagus is non-distended or whether there's a mass infiltrating the walls. Now, this patient has a very advanced esophageal carcinoma, and so we see not only the mass, which is this gray, around the white. The white is the lumen that has contrast in it, but we also see an ulceration into the mass, and that's fairly common with these esophageal carcinomas. Dr. Loy discusses esophageal carcinomas on slides 23 through 32 of his lecture, and you can refer to those for other risk factors, etc. Now, one thing I do want to say is because it's closely associated with reflux disease, esophageal carcinoma most often occurs in the mid to distal esophagus and is more rare in the proximal half of the esophagus. So we can look at these with either barium swallow or CT scan, although this patient's going to need an endoscopy at some point, so an initial evaluation with endoscopy is probably the best way to go about it if you suspect esophageal carcinoma. The endoscopy, again, can go ahead and take a biopsy of that area as well. This is just endoscopy, and you can see why we get that very irregular type appearance. This is an esophageal carcinoma. This is probably an ulceration into the wall of the esophagus. So endoscopy is very good for detecting this. And like I said, we cannot see Barrett's esophagitis at all on barium esophagram, but we can on endoscopy. And this is Barrett's esophagitis with Barrett's esophagus and normal squamous epithelium here with the columnar transition here. Now, we can't always tell, or we can rarely tell, the columnar Barrett's esophagus from just inflammation of the esophagus. And so this really requires biopsy. And again, that's something we can't do on barium swallow that can be done with endoscopy. PET-CT of esophageal carcinoma is also very useful. Not so much for initial diagnosis. It could be used for that, but it's not efficient. It's a very expensive study, so we tend to use this more for staging. And again, esophageal carcinoma, particularly squamous cell esophageal carcinoma, but adenocarcinoma as well, is very hypermetabolic, so it's very visible on our PET scan. And we look for periesophageal hypermetabolic lymph nodes. Now those aren't usually well seen on the coronal image. Those are better seen on transverse images. This is just normal activity within the kidneys, because the kidneys excrete our radiotracer. This is normal activity within the bowel. This little area here is probably a healing rib fracture. This would be unlikely to be a metastasis, number one, because it's not hot enough, it's not black enough. But number two, this is not where esophageal carcinomas tend to metastasize first. But anyway, PET-CT scan can be very useful for both staging and to evaluate responsive therapy. Now, one other thing that I just wanted to point out, because you'll see it often through your career, is that sometimes the way that esophageal carcinomas are treated, usually with radiation first to shrink down the tumor and take care of any metastasis, but then they'll need to remove the esophagus. So they will take out the esophagus, and what they do is they pull the stomach up into the chest and attach it to the very proximal esophagus or to the oropharynx. So the stomach is no longer in the abdomen, the stomach goes up into the chest. And of course, this causes problems with reflux and stuff as well. But the reason I wanted to bring it up is because it can result in some really funky looking chest x-rays. And that's what this is. This is an air-filled stomach within the chest. Sometimes these can be fluid-filled or food-filled. Oftentimes we'll see an air fluid level, so just a straight level across the esophagus. These are something that the first time or two you see these, you have no idea what's going on. It kind of freaks you out. But after you've seen 3 or 4 of them, you kind of get used to recognizing what they are. This is just a CT scan, again, with the stomach pulled up into the chest. It's almost always into the right chest because, you have the heart here in the left chest, so they usually pull it up through the right chest. And this is part of the stomach in a gastric pull-through. And so that's it. Thank you for bearing with me. The remainder of the presentations I give during this module, during your digestive module, should not be as long as this one, but if you have any questions, please get hold of me and I'll be happy to attempt to answer them.